We're really excited to have Jennifer Butler from Office of Mental Health with us. She has been a social worker, y'all, for 30 years. She serves as a program manager with BHDD OMH. She specializes in trauma informed, justice centered practice, okay, and leads cross agency initiatives that strengthen behavioral health, suicide prevention, disability, and workforce systems across the state. We are so thrilled to have her talk to you. Carrie and I like, they're our new OMH friends, really. We're just so excited about strengthening our relationship with OMH and providing you with as OMH as a resource for your folks, which they have been more than open and willing to do. So we have Jennifer Butler here today. She's an excellent presenter, y'all, and I can't even tell you, she's done so many things in 30 years. This is really just not even touching all the things that she's done and all the knowledge that she has to share. So Jennifer, I'll let you take it over.
Thank you,
Thank you so
Becky.
much.
Is my screen still looking okay for you all? Because I've somehow turned my screen blue, so I just want to make sure.
I see it clear on this end.
Perfect, perfect. Of my gifts, technology is not one. So if there's something funky that's going to happen, it's going to happen to me. But I'm very grateful to be here with you all today to be talking about pathways for healing for folks who are living with disabilities regarding trauma. I just want to thank each one of you for being here with us for this presentation. And I'm excited to explore with you how trauma-informed care can reshape the way we support individuals with IDD. I do want to say, if you have a chat, a question or a comment, go ahead and put it in the chat. I'm going to ask maybe Carrie and Becky to let me know if there's a chat message that I'm missing. I don't mind questions in the middle of the presentation, but we can also wait till the end if you feel more comfortable doing that. Basically, what I'm saying is I want this to be a conversation and not something where I'm solely just talking at you. So before we dive in, I do want to set the stage in terms of what do I mean by trauma-informed care. It's not just a buzzword. It really is a paradigm shift that's going to ask us to rethink how we interpret behaviors, how we are going to be designing environments, how do we interact with people who may have experienced trauma. We'll cover definitions, the unique impact of trauma in the IDD population, some practical strategies, some organizational practices, and even some case examples. I encourage you to reflect on your own experiences as we go along, because trauma-informed care isn't just a theory, it's about real people with real lives. So, individuals with IDD are at a higher risk of experiencing trauma compared to the general population. This includes physical and emotional abuse, neglect, bullying, and even medical trauma from repeated procedures. The challenge is that trauma responses in this population are often misunderstood. Individuals with IDD are under-identified and underserved, and often lack trauma-informed services when they're required. So, for example, a child who refuses to enter a doctor's office may be labeled as non-compliant when they're reliving a frightening medical experience, actually. Or someone who's nonverbal may only be able to communicate their trauma through dysregulated behavior. Trauma-informed care helps us shift our perspective. Instead of asking, what's wrong with you? We ask, what's happened to you? This subtle but powerful change opens the door to compassion, understanding, and effective support. So think about that in terms of reflecting back on yourselves. Let's say you had a really bad day. You come home, your loved one, your child, your spouse, your family member, whoever's there, your roommate says, what's wrong with you? And you're thinking to yourself, nothing's wrong with me. I just lived through this, and this at work today that I had to deal with it. Everything was piling on me and I didn't get lunch. And all of these things happened happened to me versus something's wrong with me, myself. So even changing again that simple statement to what's happened to you today? What did you have to go through? Can help soften that person's experience and make us more trauma informed. It provides us with the opportunity to see the individual for their entire experience and not just one singular behavior, feeling, or reaction. So, according to SAMHSA, which stands for the Substance Abuse and Mental Health Services Administration, a program, an organization, or a system that is trauma informed is the life preserver for the individual swimming in an ocean of traumatic experiences. So this starts with beginning to realize the widespread impact of trauma and understand the potential paths for recovery, as well as then recognizing the signs and symptoms of trauma in patients and clients and families and staff and other individuals involved with the system. And then responding by fully integrating this knowledge about trauma into policies, procedures, and practices. So this is a situation where knowing is great, but it's simply not enough. We then have to make sure we're implementing it, this new knowledge that we have, to make the world safer for the individuals we're caring for and for ourselves. So trauma-informed care is not a specific therapy, it's a framework. It's about embedding safety, trust, and empowerment into every interaction. So the 5 core principles are safety, which includes physical and emotional safety as a priority. When we think about trustworthiness, we're talking about consistency and then transparency to build trust. With regarding choice, giving individuals options restores a sense of control. So let's think about that child that has had a lot of medical procedures and is acting out because it's the day they need to go in to see the doctor. You might give them choice by saying, do you want me to go with you and help you communicate that you're afraid to the doctor? Do you want to go into the medical appointment taking something of comfort with you? Giving them a choice and honoring again that this is a difficult experience for them. When we're talking about collaboration, working together fosters empowerment. So often collaborating with that individual or that family and saying, okay, we got to get to the doctor. So how do we do this together? What can you tell me about what you need that we can then empower you to think about those strengths and building resilience? Okay, so think of this trauma-informed care really as the lens in which we view all of our practices. So sometimes when we talk about something like this, people go, I can't have one more thing added to my plate. And I know we're all under-resourced and we're working tirelessly to serve the individuals within our agency, our community, and sometimes many of us in our own household. This is not about adding more tasks. This is simply asking us to change how we approach the task we're already doing. Okay, so if you're already doing assessments, if you're already doing therapy, if you're already just having meetings and communication, how can you do this through that trauma-informed lens?
What?
So let's talk about the unique vulnerabilities of individuals with IDD. As I mentioned before, they're more likely to experience trauma due to dependence on caregivers, some communication challenges, and social marginalization. These experiences can leave lasting imprints, especially when the individuals lack the language or the cognitive ability to process what happened. Trauma-informed care acknowledges these realities and seeks to mitigate their impact. So on the slide, you see several stats. You see that they're 2 times more likely to experience emotional neglect and physical and sexual abuse, 4 times more likely to be victims of crime, 2 times more likely to be bullied. All of these things are things that they carry with them. I don't know about in your particular fields or disciplines, but in social work, we often, or in the early days, heard you leave yourself at the door as a clinician. We know that's not even humanly possible. I am not a social work robot. So anything in my life that has happened, I carry that into me with experiences. And that is true of those that I work with as well. So for me, I had a child who at 4 days old was unresponsive and had to be rushed into the ER. And we spent the next 3.5 years of her life with daily medical interventions and then additional medical interventions on a quarterly basis and a yearly basis. And we were one of those families that taking a child in to see the doctor actually wasn't the doctor that was the problem, because the doctor just ordered the procedures. It was as soon as a nurse walked in, we had the reaction because, of course, my daughter was like, I'm having all these invasive things and I'm a little toddler. And even before that, a baby, and I don't even know how to communicate what's happening. And as a mom, I had anxiety every time we had these things happen. And it wasn't that I had uncaring practitioners. It was that I don't know that anyone ever had the thought process or the training to say, let me think about this through a trauma-informed approach. How can I talk to this mom about how to help her child? How can I help this child in this moment get through this moment that we have to do? There wasn't a way around it, but how we got there could have been different. And even as a longtime therapist, I still, in that moment with my own child, needed support in how do I help her and myself in this trauma-informed way. But again, that's something we all carry with us to this day. Even she's now 24, and even when she goes to the doctor now, sometimes it is, Mama, are you coming with me? Because this is still something we carry with us. So trauma doesn't always look like the classic PTS symptoms we might expect, especially in individuals with IDD. Trauma often manifests through behaviors. Examples include aggression, withdrawal, self-injury, regression in skills. So maybe you're thinking to yourself, I don't understand why they're falling apart in a puddle over here. There have been other challenges that they've been able to overcome. Well, we never know when trauma is going to be triggered, where it lies in our body and our mind and our emotions, and where that might get activated or how that's going to get activated. Emotionally, we may see anxiety, hypervigilance, or difficulty trusting others. It's important to remember that these are survival responses. They are adaptive in the face of perceived danger. So if you think back to caveman days, our bodies were hardwired to have blood rush to our extremities, so our hands and our feet, so that we could fight off what was happening. We could then run. So back to, again, caveman dinosaur days, this was how we were meant to survive. Our bodies have never outgrown that. That instinct is still within us. So when we feel threatened because we have experienced past trauma, or we've seen someone we love who has experienced trauma, or even maybe it's not even someone that we even know, but we've seen a traumatic incident, whether in person or on television. If you think back to the news cycles that we've had to endure in the last several years and even the last several weeks, that can give us trauma, that can heighten us, even as practitioners and caregivers working with individuals who've experienced a lot of trauma. That eventually begins to take home within our own spirit. Okay. And so then we respond as a mean to try and survive the moment. When we reframe those behaviors as communication versus something that they're just doing intentionally to act out, to be willful, to be non-compliant, when we really see them for what they are and go, what are they trying to say with that self-injurious behavior? What are they trying to say by screaming or refusing? Then we can respond with empathy rather than punishment. So trauma shows up differently across developmental stages. And for people with IDD, those differences can be even more pronounced because, again, communication, sensory processing, and support needs shift over time. So in early childhood, at this stage, the children may not have the language to express fear or distress. So think about my daughter, unresponsive at 4 days old, and that was when we began the next 4 years of daily medical interventions. Okay, as an infant, I like to say children don't come into this earth speaking our language. They have to understand us. They don't have the words. For most of that time period, she didn't have the words to even express something, right? So trauma often shows up through changes in regulation. So that may mean they're difficult to calm down. They may have increased aggression, or they may need more reassurance than usual. What looks like a tantrum may actually be the fear response. And with someone with IDD, this early childhood stage may carry over longer beyond what those traditional age groupings are.
Okay. There's another one here they just sent me.
So in middle childhood, as children grow, they still lack the expressive or receptive language to describe intrusive thoughts or memories. So trauma may appear as withdrawal, irritability, or even sudden changes in behavior or learning. Providers may interpret this as non-compliance rather than a stress response. So remember that question I posed a couple of slides back. Not what's wrong with you? Why are you doing this? Why are you acting this way? What's happened? Or even what's happening right now. Can you tell me where in your body you're having an emotion? Where are you feeling this? So one of the things that I used to talk with my own daughter about is we have to learn how to soothe ourselves when we're mad or we're sad. Keep it really simple and concrete. Sad feels like this in a person's body. Sometimes when people are mad, they feel like all tensed up and you may physically show them. We're teaching them, just like we would teach them any foreign language. Emotional language is a foreign language for them. So giving them the words, helping them understand what that body feels like, and then honoring that and respecting that and saying things like, it must be really tough to have to go to the doctor so frequently and really scary. I imagine I would be scared too. Let's talk about how we can help each other manage that fear when we go to the doctor. In late childhood and young adulthood, trauma can disrupt the ability to build trusting relationships. So you may see withdrawal from peers or caregivers, reluctance to engage in school or community activities, or even a drop in motivation. This is a period, though, when identity and independence are developing. So trauma can significantly impact confidence and connection. So for some folks, for a great many folks who have experienced trauma, we see them maybe developmentally stop or halt at the age where they experience that trauma. So for example, if someone is sexually abused at 12, even though now when you're working with them, they may be 18, they're still emotionally at that 12 because their entire emotional development was impacted by the level of trauma at that earlier age. So just because someone is a chronological age does not mean they fall into the developmental level of that chronological age. We all respond differently based upon what our experiences have been in life. When we look at adults with IDD, they may carry long histories of unrecognized trauma. It can show up as mistrust of caregivers, chronic health complaints, difficulty maintaining employment or relationships, or avoidance of situations that feel unsafe. So emotional numbing, anxiety, or depression may be present but overlooked. When we talk about seniors, these older adults may experience trauma through medical procedures as well, the loss of peers or caregivers, or increased vulnerability to neglect or exploitation given their aging process. Trauma may look like heightened fear, withdrawal from activities, or increased dependence on routines. Stress can even worsen cognitive changes, making trauma harder to identify. Across all ages, here's what I want you to remember. Behavior is communication. What are they trying to tell you? When we understand how trauma may present at different life stages, we can respond with empathy, predictability, and support rather than punishment or blame. I'm not a perfect parent by any means, but I do try to remind myself not to punish the emotion out of my child. And when I was in active practice with folks who were living with personality disorders and complex needs, I kept saying, to myself in the session, don't punish the emotion out of them, redirect the behavior, because emotions keep us safe. They communicate to us and they communicate to the world around us, and they're really not the problem. It's not knowing how to manage them or even how to manage my own feelings about needing to say what's happening to me and not having the words. So again, behavior is communication. So that leads into this slide of capturing the essence of that. Remember the question, what happened to you, not what's wrong with you. Instead of labeling behaviors as bad, ask, what is this person trying to tell us? What need is unmet? And what past experience might be influencing their reaction? For example, if a person refuses to enter a crowded cafeteria, maybe they're experiencing a communicating sensory overload or fear of bullying. Trauma-informed care helps us decode those signals and respond appropriately. So I want you to think for a second about the last time you had a visible reaction, either good or bad. Did your behavior or body language communicate all that you felt internally? So I'm going to say that one more time. Think about the last time you had a visible reaction, either good or bad. Did your behavior or your body your behavior or your body language communicate all that you felt internally? Did they match? Did those responses betray you by showing something more? Did you find a way to clarify what you were trying to communicate? We've all been there, right? Where maybe you think you have a good poker face and everybody saw the reaction on your face and it communicated more than what you meant, or in a way that you didn't mean to. Or I would have patients, because I have chronic migraines, and so when they would come in for the session, I would say, hey, I've got a migraine today, so if you see me doing like this, or looking pained, or looking like I just am unhappy, it has nothing to do with you. It has to do with my body is reacting and giving a physical representation, but it's not matching my actual feelings about you. It's about my own physical internal cues that are happening. We've done this with our spouse or our children, where we've given them the look, right? Seen everybody familiar with the look? And you are communicating, but maybe you're communicating without full context. Again, behavior is communication. So how do we put trauma-informed care into practice? Here are some of the core strategies. Predictability and routine. Consistency reduces anxiety. Okay, so making sure that if you know this individual doesn't do well with morning medical appointments because they really need to kind of warm up to the day, and they do better in the afternoon when maybe it's not as cold outside or it's sunnier, and then afterwards being able to go outside and feel the sunshine on their face, then try to schedule all the appointments in the afternoon if possible, but be consistent. And even if you can't make sure the events are consistent in their life, you be consistent. So one of the things that I used to say to folks that I worked with is, you're not going to have to guess with me. I'm going to say what I mean. So if I tell you you're doing a great job, I mean that. And you can take that to the bank and you can hold on to it. If I say, listen, this isn't a helpful reaction right now. Tell me what's going on. Let's figure out how to get your needs met effectively. Then I mean that, right? So if the events around them can't be consistent, you be consistent. Use clear communication. Use simple language, visuals, or social stories. Sensory-friendly environments. Reduce noise, harsh lighting, or overwhelming stimuli. Okay? Offer choices, even small choices, restore a sense of control. Okay? So remember, if you've been a parent or you've ever had to work with young children, you may say to them, hey, okay, you can wear the red shirt today or the blue shirt today. Your choice. Well, you've essentially already made the choice. You're okay with the red or the blue, but they get empowerment in choosing which one they want of those two choices. Okay, so thinking about giving them as much choice as we possibly can, because that gives me a feeling of safety, okay? These strategies don't require major resources. They require intentionality. By embedding them into your daily practice, we create environments where individuals feel safe, understood, and supported. So let's walk through a case. Imagine a young adult with IDD who becomes aggressive during medical visits. A traditional response might be restraint or sedation, but a trauma-informed approach looks different. You might prepare with visuals or social stories that will explain what will happen. Offer choices like which arm to use for blood pressure. Provide calming sensory tools like maybe taking a weighted blanket or a fidget. This reframes the medical visit from a threatening experience to a manageable one. The goal is not simply compliance. The goal is dignity and empowerment. So I want to say that part again. The goal is not just compliance. It's about dignity and empowerment. We all want to feel like an individual sees us, not that you see me sitting here in a pink and black sweater, but that you see me. You see me as a person who has had, now all of you who I don't even know, I've now told 83 people that my daughter and I went through a difficult time in the first 4 years of her life, right? I want to know you see me and that you go, oh, okay, I get her a little bit more now. That's what trauma-informed care is about as humans. And we can do this no matter whether you're doing this in your workplace, do it at home, do it with the cashier at Publix, right? Ask them how they're doing and actually mean it. right? Pause for the answer. This is how we maintain and we build dignity and empowerment. Trauma-informed care must extend beyond individual interactions. We have to embed this in our organizational culture. So this means training staff in trauma-informed principles, developing policies that emphasize dignity and respect, leadership, modeling trauma-informed values. When organizations commit to trauma-informed care, they create environments where both individuals and their staff feel safe, supported, and valued. Trauma-informed care isn't just about mitigating harm. It's about building resilience. And when I say resilience, I mean coping through something, right? Like we had said 2 slides before with the case example of the medical appointment, still the person had to go to that appointment. They had to cope through it, right? Versus avoid it. So we do this by focusing on strengths rather than deficits, encouraging self-advocacy and independence where we can, promoting community inclusion and belonging. So this resilience, like this tree here, grows when individuals feel that empowerment, that connection, and when they feel capable. Trauma-informed care helps us cultivate these conditions. Of course, some challenges exist, right? Limited resources, staff burnout, and misinterpretation of trauma behaviors are common barriers. For example, staff may feel frustrated when behaviors escalate, especially if they don't understand the trauma context. Organizations may struggle to allocate time and resources for training. I want you to remember, though, we don't have to carry these challenges alone. Acknowledging these barriers is important, but trauma-informed care provides a framework to navigate them with compassion and creativity. So one of the things I think that excited Becky and Carrie and myself and my 2 colleagues that were with me on Friday in our meeting was how many ways that actually we could intersect and hold each other up and support each other through initiatives, through taking care of our staff, through taking care of South Carolinians, right? So many different touch points that we shared that we didn't know about before. And that's one of the beautiful things about this merger is being able to go, oh my gosh, I didn't realize I had to do this all by myself. I now have partnerships. I now have friends in this. And that's, again, that organizational culture and shift regarding trauma-informed care. So let's talk about some practical tools that you can use tomorrow. Okay, so visual schedules increase predictability. So what does that look like? That may be a calendar on the refrigerator. That might be something in the group home that says, here's when appointments are, here's where groups are, activities are, right? Calming kits with sensory items like stress balls or noise counseling headphones. Trauma-informed assessment tools that identify triggers and tailor support. So learning those assessment tools and how to ask questions about what sort of trauma somebody's experienced. These tools are simple, but they're powerful, and they help individuals feel safe and understood and empowered. Here's a QR code that if you have your your cell phone with you, please take it out. Please go ahead and use the QR code. This is one of the best resources South Carolina has provided to every single South Carolinian, all 5.2 or 5.3 million of us, okay? We're the only state in the country that has done this for every member person in our state, right? All you have to do is have a way to get online. Okay, so Hopeful Minds is a free online platform that brings together expert-rated and vetted videos, podcasts, apps, online programs, books, and articles, all in one easy-to-use place. It's confidential and it's available 24/7. You can learn new skills, you can understand your own mental health, you can take a mental health assessment, you can browse library of thousands of mental health well-being resources. So when you look at the QR code and you pull up Hopeful Minds, and it will work on your phone, your computer, it's going to ask you what county you reside in. All you do is click that county, okay? And that's really to make sure that we're kind of funneling you to the resources in South Carolina that are in that area. It's then going to ask you if there's something in particular you're looking for. So I'm going to give you an example of something that where I used Hopeful Minds with my son. So I don't do any social media. I'm not even on LinkedIn, never have been, don't want to ever be on any social media whatsoever. I did not let my daughter before she was 18. I don't let my son. Too many dangers. We won't go down that rabbit hole today. So what I will say is that as an athlete, last year when he was starting to run cross country for the first time, he was like, I feel really anxious when it gets time for a meet. And I said, let me tell you about Hopeful Minds. I showed him how to get onto Hopeful Minds because I trust that platform. I know it's vetted. I work closely with the team that created this Credible Minds platform, and they've helped us with our Hopeful Minds. And I said, here's what you do. Look on there for anxiety and then search for sports anxiety for athletes, okay? And I let him go and research that. That's empowerment. That's independence. It's giving him choice. It's giving him information that I know I can trust, right? When my rheumatologist said, you have noisy knees, you need to take Tai Chi, and I was like, before I go and pay for Tai Chi, let me see if it's on Hopeful Minds. And it was. There's some Tai Chi videos on there. And so I would shut my door when we had offices at the old state office building, and I would do it at my lunch break off of Hopeful Minds. My mother-in-law has dementia. And when she was first diagnosed, it was very hard for my husband and his brother. And I said, please go on Hopeful Minds and look at caregiver resources, understanding dementia, how to help someone at the various stages. So I bring all that to say, it is a beautiful resource that I hope you will continue and save and bookmark and log into every single day. Log into it not just when things are challenging, but when things are great, to continue building up your strength, okay? Building up your coping skills toolbox. I promise you will enjoy it. You don't have to sign up on Hopeful Minds, but if you do sign up for kind of registering yourself, no one ever sees that Jennifer Butler looked up Tai Chi. Jennifer Butler looked up dementia care resources. That never happens on that name level. We get, oh, one more person logged in today. But what it does for you by registering allows you to begin to save resources. And then you also get a weekly and a monthly newsletter from them that says, here's some topics of interest. It's National Disability Awareness Month. So maybe they send you something regarding that. Or it's National Mental Health Month. Have you taken care of yourself this month? Okay. So it's a great, great resource that I hope you have all put in there. And Carrie and Becky also have the flyers for Hopeful Minds that you can post around your workplace or in your communities. Please, please, please share this. No age limit, totally free. So I want you to take a moment to pause and reflect. Think of a time when you've encountered a behavior that frustrated you in someone else. So get that time period in your mind, time when you've encountered a behavior that's frustrated you. Now, I want you to ask yourself, How might trauma-informed care reframe that behavior? Could it be communication of fear, pain, or unmet needs? Meaning, if you knew then what you know in the last 30, 45 minutes, would the reaction have been different from you? It may have still been a frustrating behavior, but would you have understood it differently? Would you have seen it differently? This exercise helps us internalize the trauma-informed lens. It's not about perfection. It's about curiosity and compassion. So to wrap up, and then I'll take down the sharing and we can ask questions, or you can say, hey, this is going on with me, or do you have a resource about that? But before we do that, some key takeaways. Trauma-informed care is essential in the IDD population. It is there, whether they articulate it or not. They're more vulnerable to it and more vulnerable to having it compounded throughout their lifetime. Behavior is communication, not problems. Safety, trust, and empowerment must guide our work. And an organizational commitment is required if there's going to be lasting change. If you remember nothing else, remember this. Trauma-informed care shifts our perspective from fixing behaviors to understanding people. So it shifts our perspective from trying to just fix a behavior to understanding people. So I want to thank you for your attention and your engagement, and I'd love to hear your questions or reflections or experiences now.